Hello, this is Erin Callahan from Brandman University with a case presentation on epigastric pain for class Neuro 673. This patient's chief complaint was concerns about weight loss and abdominal pain. This gentleman is a 43-year-old male with a history of bipolar disorder, COPD, history of pulmonary embolism, who presents to the clinic for continued lower and epigastric abdominal pain after endoscopy, which was performed on October 7, 2020. Patient was found to have a hiatal hernia with evidence of Barrett's esophagus without erosive gastritis. This was listed on the endoscopy report. Patient was prescribed omeprazole and Pepcid at the time of his endoscopy, but only just received them in the mail today. Patient has not started on the medications. Patient also reports decreased appetite since April when he was diagnosed with pulmonary embolism and in the hospital. Patient denies nausea, vomiting, diarrhea, but states he has to force himself to drink liquids. Patient has lost more than 20 pounds since his hospitalization in March for his pulmonary embolism. Patient also reports insomnia. For review of systems, the patient presents under general constitutional, denying chills, fever, any weakness. He does admit sleep disturbances, insomnia, which he thinks is due to his bipolar. Ophthalmologic, patient denies blurred vision, denies discharge, denies any eye pain or visual disturbances. For ENT, patient denies hearing loss, denies sore throat, denies difficulty swallowing or swollen glands. For endocrine, patient denies cold intolerance or heat intolerance, excessive thirst, but he does admit a weight loss around 20 pounds since his endoscopy. Respiratory, patient denies cough, denies shortness of breath at this time, denies difficulty with the COPD exacerbations, denies any shortness of breath with exertion, again, denies any wheezing at this time. Cardiovascular, patient denies chest pain with exertion, denies any irregular heartbeats recently or any shortness of breath. GI is the main complaint of why this patient is coming in today. He complains of having epigastric pain for months, which starts off in the upper epigastric area and then kind of moves down lower into his abdomen. He denies any nausea, denies vomiting, denies diarrhea. The abdominal pain feels kind of like a burning pain in the epigastric area and then a more dull, achy pain in the lower abdomen. His bowel habits have been normal. Again, denies nausea, vomiting, diarrhea. For genital urinary, patient denies any problems urinating, any difficulty urinating, any pain with urination or blood in the urine. For musculoskeletal, he denies any issues with pain in his joints or stiffness or any weakness. He's able to move all extremities without difficulty. For skin, patient denies any rashes at this time, denies dry skin, denies any itching. Neurologic, patient denies fainting, dizziness, headaches at this time. His past medical history is a long-standing history of insomnia, PTSD, bipolar, schizophrenia, depression, and also a closed fracture of his right foot, which is healing, and subsequent encounters for that fracture. His surgical history includes left knee surgery, tonsillectomy, and that compound fracture of tib-fib on the right side. Hospitalizations, major diagnostic procedures. Of course, he just had the endoscopy done, but also he was in urgent care September of last year for back pain. This patient is on a plethora of medications. I reviewed his entire medication list with him. His caseworker is also in the appointment with us to make sure that he is taking all of his medications. He's on cyclobenzaprine muscle relaxant. He's on several inhalers for his COPD, including montelukast sodium tablets, but also Flovent inhaler, Spiriva, Ventolin inhaler. He also takes Tylenol for pain as needed, Zofran as needed for nausea, although he says he hasn't been nauseous recently. He also takes Minipress for blood pressure, high blood pressure. He takes Simvastatin for cholesterol. He takes vitamin C. He takes cetrizine for allergies, seasonal allergies. He takes Abilify for his psychiatric diagnoses, Flonase again for allergies, Symbicort again for allergies and COPD. Not taking Xarelto at this moment. Before he went in to get his endoscopy, he was diagnosed with a pulmonary embolism prior to that, and so he was placed on Xarelto at that time. He did not take Xarelto for 2 days prior to his endoscopy on the 7th of October, and when he was finished with his endoscopy, wasn't sure if he was supposed to continue taking Xarelto, so he stopped it on his own. Patient was informed on this visit that he needed to start his Xarelto back up because he is high risk for another pulmonary embolism or blood clot. Patient was prescribed pantoprazole 40 milligrams once daily before breakfast at the end of his endoscopy visit, and we found it on the record for his visit that it was prescribed. He has not taken it yet because he just got it in the mail prior to this visit. He is allergic to lithium with a reaction of anaphylaxis. This patient has a family history of 2 brothers, 1 sister who are healthy, history of drug abuse, although he has not said which kinds. He claims that he is not using any recreational drugs at this time. His alcohol screening did show that he does drink occasionally, monthly or less than that, but not more than 1 to 2 drinks at a time, and never more than 6 drinks on one occasion. So at this time, negative alcohol screening, he denies smoking marijuana. Physical exam findings include objective vital sign temperature 97.3 Fahrenheit, blood pressure of 122/86, heart rate of 74, weight 189.8 pounds, height 74.4 inches, BMI calculated at 24.1, oxygen saturation 99% on room air. Physical exam, his general appearance, patient is well developed, well nourished. He doesn't appear to be in distress. However, the patient is disheveled and smells very foul in this room. Although he has a mask over his face, the odor is very strong, and the patient just has messy hair and kind of disheveled appearing. Head, normal cephalic, atraumatic, eyes, pupils are equal, round, reactive to light and accommodation, sclera, non-icteric, ears, normal. I'm able to visualize the TMs on both sides and it's clear. Oral cavity, mucosa is moist, no erythema seen. Throat is clear. Neck and thyroid, neck is supple, full range of motion, no cervical lymphadenopathy. Skin, warm and dry, no suspicious lesions. Heart rate is regular. Rhythm is regular, S1, S2, normal sounding. No murmurs, auscultated. Lungs, clear to auscultation bilaterally. No wheezing heard in any of the lung fields, although the patient does have a history of COPD. He says he has not had to use his inhalers recently. Abdomen, for this visit, this was my focused assessment. His abdomen was soft, non-tender. It was non-distended. Bowel sounds were present in all 4 quadrants. Normal exam, benign exam for the abdomen. Extremities, no clubbing, cyanosis, or edema. Patient able to move all extremities, walks with a steady gait into the room today. Peripheral pulses were normal. Neurologic, non-focal exam, motor strength normal in upper and lower extremities, sensory exam intact. Patient is alert and oriented on this visit. The differential diagnosis and treatment plan for this patient. My assessment for this patient was his chief complaint of coming in was epigastric pain, ICD-10 code R10.13, also long-standing history of GERD, which is still upsetting him in this moment, ICD-10 code of K21.9. Patient was found to have Barrett's esophagus on his endoscopy report, which was faxed into our office, giving him ICD-10 code of K22.70 on this visit. My plan for his conditions are to continue on his current medications, start his pantoprazole as directed, and also resume on his Xarelto at his previous dose. I would like him to return to the clinic within 6 weeks for follow-up once we have the biopsy results from his endoscopy so we can review those results with him and change any kind of medications or treatment plans at that time if needed. Patient was instructed to return sooner if he has any concerning symptoms or new symptoms, or to please proceed to the closest emergency room if his symptoms worsen. The clinical practice guideline that I consulted to develop this treatment plan was one that I found on American Journal of Gastroenterology that discusses treatment and management of Barrett's esophagus. We already know that this patient has a long-standing history of GERD. We know this patient has long-standing epigastric pain. We did not know about his diagnosis of Barrett's esophagus until we reviewed the endoscopy report. Therefore, I did consult the clinical practice guidelines, and one of the key items that was listed in the CPG was to make sure that the PPIs that were prescribed to these types of patients are only once a day, not twice a day. So that is how his pantoprazole has been ordered, 40 milligrams once daily to be taken half an hour before breakfast. There were other guidelines on the clinical practice guideline as well, but they were already followed up by the GI specialist. Patient was also advised to follow up with their psychiatrist about his psychiatric medications in case any adjustments need to be made, which might help his insomnia.